I want you to start, let's start off by introducing yourself. I want Dr. Pierre KUBI to start his introduction.
Thank you for having me here. My name is Dr. Pierre KUBI. I'm a medical doctor by profession. I'm a final year PhD student at the Department of Obstetrics and Gynaecology at the Chinese University of Hong Kong.
My name is Dr. Amoafo-Mensah. I'm a medical doctor in London, and I've been working in a large teaching hospital during the COVID-19 pandemic.
So my name is Nana Tima, and I work with the Ministry of Education. I am the Deputy National Coordinator for the Free Senior High School Secretariat.
By the way, I have my wife who's going to be my co-anchor also, someone in the background. She'll be joining us with comments.
Good morning, and good morning to all the participants and your audience. So my name is Chris Owoo. I'm a consultant anesthesiologist and intensivist. I'm head of ICU in hospital, and I teach for the university. I coordinate the national COVID-19 severe and critical cases for Ghana.
Okay. All right, so let me just start off by telling you why this conversation has become really important. There are lots of people who actually think that COVID-19 is a scam. Some people call it a scamdemic. But we all know, and the reason why I brought you on here is because some of you, in fact, virtually everybody has been at the front line of this pandemic fight. We have frontliners, health workers who have seen this firsthand. And then we also have people who have survived COVID-19. And they're going to join us to tell us their story. I want to start off with Nana Tima, who is a COVID-19 survivor. So Nana Tima, tell us what the experience has been like. First of all, how you think you got COVID-19.
Israel, so it's difficult to tell how I got it, even though, and I've been saying this, it's easy for people to think that because my boss got it, and my boss is the Minister of Education, Dr. Prempe, and other colleagues in the office got it, it's easy to assume that I may have picked it from him or from the office or from my other colleagues. But I say that I kind of disagree. I really don't know where I picked it from. And it could be that I may have picked the virus from somewhere else. I could even have passed it on to him and my colleagues. So I could have picked it from anywhere. So I don't really know where exactly I picked it from.
At what point did you get to know that you had COVID?
So I started feeling unwell on Friday evening. Friday was 19th June. I had worked from 4 a.m. that day, so I assumed I was tired. And when I say I started feeling unwell, I was feeling tired and I was feeling hot and cold, generally feeling unwell. I didn't have a sore throat. I didn't have a high temperature. I wasn't coughing. And so with only tiredness, and when you Google the symptoms of COVID-19, the three that are supposedly the most common symptoms are tiredness, the dry cough, and then a fever. So because I didn't have a fever and a dry cough, I didn't think it was COVID. So I rested on Friday night, and on Saturday morning, I was okay. I wasn't feeling unwell anymore. So I assumed it was malaria. So on Saturday, I went about my normal I went to do my normal rounds. And then later that day, around 12, I started feeling unwell again. It really presented like malaria. Like I was feeling hot and cold and I was feeling unwell. I would sit in the chair and I would sit on the floor and I would lie down. So I called my doctor and she said, immediately she said, well, this could be COVID. And of course, I didn't want to have COVID. So I said, no. I don't have a cough and my throat is not itching or anything. And I don't have a high temperature. So she said, okay, fine. Let's start you on a course of malaria, even though I hadn't tested for malaria. She said, let's start you on an anti-malarial course and let's see. So on Saturday evening, I got anti-malarial tablets and started taking them. And then she asked me to start vitamin C, the soluble vitamin C tablets as well. On Saturday, in fact, on Saturday, I didn't sleep much. So on Sunday morning, it was really bad. I couldn't even get myself out of bed. So I called my mother. I was then in Kumasi attending the MPP primaries. So my mom is in Kumasi as well. I called in and she came over. Fortunately for me, my mom sells in the market and she always acts as if she has the virus. And so she always has a mask on. And so she was telling me that she could have the virus and she doesn't want to pass it on to me. So she wasn't coming close to me. And she had her mask on the whole time she was with me in the room. So on Sunday, I managed to get to Accra. I went to Kumasi with my driver. So I came back to Accra with my driver. It was very difficult because I was feeling unwell. I came to Accra, got home, and my doctor called and said I needed to immediately isolate because I have 3 toddlers. And I live with my husband and my cousin. So it wouldn't be good if they caught it. So I immediately locked myself in the bedroom I share with my husband, and he had to move out. On Monday, I was still not feeling well. And by noon, I got a call from the office that one of us had tested positive for COVID. And so we immediately needed to isolate. And our phone numbers had been given to the contact tracing team. And so they would call us and come and take our samples. I got the call on Tuesday morning. But then on Monday evening, my boss called and said he had been admitted at UGMC, but his test had come negative, and so they were going to do further tests. I was called on Tuesday. I needed to drive myself to the clinic at the Jubilee House because the contact tracers weren't going to come to me. I had to go and take the test. And because I didn't want to pass on the virus to my husband, I needed to drive myself. So I told the tracers I couldn't come on Tuesday. I went on Wednesday and I took the test. But by Wednesday when I was going to take the test, I knew that I had COVID. I wasn't really waiting for the results. So I was started on a course of antibiotics. I had to continue the soluble vitamin C, soluble vitamin D, zinc tablets, some other drugs, which Dr. Petrina prescribed. I got the results back on Friday, but by then the symptoms were full blown. I had totally lost my sense of taste and smell. I couldn't smell anything and I couldn't taste anything in my mouth. And as I wrote, the symptom that was the most difficult for me was the feeling of unwellness. It was like, I didn't know what to do with myself. I was feeling very sick. And because no one could come close to me, it was quite painful because it was kind of like just me locked in my room with my TV and my books, you know. So it hasn't been a good experience. As I wrote on my page, fortunately, my colleagues in the office had also tested positive for the COVID. So it was just, we joked that we had communal COVID. And so I would wake up and call one of my colleagues and she would say, this morning I had a cough. And the other person would say, this morning I have a high temperature. And the other person would say, this morning my head is aching. So we were discussing what we were going through. And it felt good to know that I wasn't alone in all this. And I had other people who were going through the same thing. The only thing is that all of us had very different symptoms. And there were 2 or 3 people on the team who were totally asymptomatic. They didn't have any symptoms at all, even though they tested positive as well. And so generally, that is it. The most interesting thing is that when my mom found out my boss had tested positive, she called me and the way she asked, she was like, I had to say this in Chi. And I quickly had to say no because I know my mother. She's a typical market woman and she wouldn't understand. And I didn't want her to take the lead to the afterworld before me. So I had to lie to my mother that, I had tested and I was negative and so I'm fine. And so anytime she called, she would ask where the kids are. And I told her because my boss has tested positive, I have to isolate just as a precaution so the kids are not coming close to me. And I think she assumed that everybody who has tested positive is in the hospital. And so because I was home, she believed that I didn't have the virus. When Dr. Petrina called me on Thursday morning to say I was positive, she said I needed to check myself into UGMC, like into the hospital, because then I had lost my sense of taste and smell. I had a very slight cough. It wasn't It wasn't a very strong cough. It's just that when I tried to talk, people were calling me on the phone a lot. So when I tried to talk or when I tried to laugh, you would hear me coughing. I read that the COVID cough is supposed to be wet, it's supposed to be dry. But I did have a productive cough, not very productive, but I did have phlegm sometimes when I coughed. And then I started throwing up. I had diarrhea. When I drink water, it would come out. When I anything I tried to eat would come back up. So I had to make do with popcorn because that was, I mean, especially tasteless and it's easier to take gradually. So at least I have something in my stomach. So when Dr. Petrina called back on Friday and I said the nausea was so persistent, I was still throwing up, she asked that I immediately check into the hospital, which was a problem for me because I'm sorry, but I hate hospitals. So I told her, okay, let's wait till Saturday morning. If I don't feel better on Saturday morning, I'll go to the hospital. Now, I must say that I don't know how the doctors do it, but this might sound cliche, but without the doctors, I don't know how I'd have gone through this. Even though they say there's no medication for it, it's nice to have the doctors well again. Maybe it's because it's me, but it was nice to have the doctors calling in every morning to check and see how I'm doing, how the symptoms are, how I'm holding up, and then adding on medications depending on what symptoms I was showing on that day. So generally, that was it. A couple of people called me when I was sick, and I said I didn't have the virus. I said I had tested negative because this is me being petty. And I also felt that they were just being nosy because these are not people that would usually call me or would usually check on me. And so what are they looking for? Why are they suddenly asking me if I'm positive? And I was also very confused then. What pushed me to want to talk about this? There are two things that pushed me. One is the fact that the symptoms that people are asked to look out for are not the symptoms that I had. And so I'm thinking that somebody would have malaria-like symptoms. The person would take antimalarials and go to work, or the person would take antimalarials and go about their normal duties. But they could have COVID and they could be infecting other people. The other reason is that one of my colleagues tested positive. And he called each one of us in the office separately and told us that he had tested negative, which I found quite strange. It was like he was putting in special effort to tell us that he was negative, even though nobody had asked him. And we all knew he was positive. So I felt, hey, I mean, what's wrong with being positive? We should rather be grateful to be alive. The night that I found out Sir John had died, I didn't blink. I didn't sleep at all that night because I had gone for a walk and returned at 7 p.m. So I lay down. I was reading. I picked my phone around 11 p.m. And Sir John and I are on the government CEO's platform. And so I saw they had changed the name of the platform to RIP Sir John. And I thought I was dreaming, only to open and see messages of condolence and people saying he was actually recovering and they brought him his food and then he just dropped off. And it was a very emotional moment for me because I felt that I'm no better than Sir John. Sir John is a very energetic, even though he's older and he may have had underlying health conditions. I am no better than him. And this was me lying in my bed and, taking this very calmly. So I was a bit overwhelmed that day and I just couldn't stop crying. I cried till morning. I was grateful to God that I was still here and at least all my colleagues are still alive and they were all recovering. But then again, I was pained. I was thinking, how is the virus doing its selection? Who is it killing and who is it leaving? And so the following morning, I remember I called Oheneba Danso, the Kofanochi CEO, and he was telling me, because it's a new virus, research is still going on. They don't know who it's going to kill, and we don't know who is going to survive. And that is why we need to make sure we don't get it, because I may get it and I will survive. You may get it and you won't. And so whatever you do, try to avoid getting the virus. Do all that you can to avoid getting it.
Okay. All right, Nana Tima, I'd want to go to Dr. Chris Owoo at the moment because he is one of the frontliners. He actually works in the ICU. He coordinates the ICU as far as Ghana's national COVID responses. So, Dr. Owoo, I'm sure you have encountered people like Dr. Owoo, you've encountered people like Nana Tima, and some whose cases were a lot more critical. What do you make of people who say that COVID-19 is a scam?
First of all, I want to say, Nana Tima, we thank God you've recovered quite nicely, and thank you for taking up the opportunity and having the courage to share your experience with others. We've been going through this for about 4 months now since Ghana had its first case on the 12th of March. Basically, I think we are exactly 4 months now since we had our first case. And, initially, we all thought that this was going to spare Africa and wasn't going to touch everywhere. There were sets of people who thought that this was the disease of the elites or the bourgeois, and therefore it was those who were coming back from travel who we mandatorily quarantined, who were to be worried about. But quite early, when we had seen what was happening in places like China, Germany, Spain, UK, and eventually in the Americas, we knew that this was going to come home to us. It's not everybody who has been able to go through this without any symptoms, or everybody who has been able to go through with symptoms that may be bothersome, but still do not require hospital or did not have to go into hospital like Nana Tima did. There are some who spent quite significant period of time fighting for their life. And there are some who unfortunately have lost their life. And I think we're quite aware of that as a nation. I want to also take the opportunity to thank all my colleagues, both at the national level, regional, and all the way to facility levels who are putting in their best to try to protect our country and deal with the problem. And then the patients who've gone through our hands, and also say my condolences to the families of all those who've lost loved ones. We share in their sadness and their grief. And this is a very good reason, as Nana Tima said, to fight to reduce the spread. You're not going to know who is going to make it. You don't know who will require intensive care.
Right, so we're getting feedback from someone. So if you could just mute your microphones until you're speaking, and then you can unmute them, so we can hear.
All right.
Oh.
Okay. So I think in late March, just about when our number of cases was going up, and I think early April, when we lost the first few cases, at that point in time, we were basically still going through the process of setting up treatment centers. I got involved in this because two of my very good friends, colleagues, Dr. Oliver Komi and Dr. Lawrence Oforibuedu, called me up and said, look, what's going to kill people is those who will end up requiring ICU. I man an ICU in KBTH Hospital, and they asked me to join. And eventually I was co-opted into the national team. Now, in early April, we started losing people. It were one today, another 3-4 days, maybe another one. And there was even debate as to whether really people were dying from COVID or people were dying from other conditions and then wrongly diagnosed as COVID. But yes, the main issue at that point in time was that we hadn't even set up intensive care units to tackle COVID. And it wasn't because we didn't have intensive care units. Yes, we have difficulties in our health system. It's not as strong as we would want it to be. But our intensive care units were already overwhelmed by disease conditions because there were not a lot. And because this was an infectious disease of which a lot was not known about, we knew we could not miss the patients. We did not have the facility and the technology to make sure that people missed in the same intensive care unit or did not contract the disease or did not spread the disease to others. So we had to start setting up ICUs, and there were a couple of patients we lost. Unfortunately, I can't mention the name now while we were trying to set that up, and I basically was thrown a task of setting up intensive care units in a hospital that was yet to be used in their delivery suite, basically what we call a labor ward, in 3 days. With the help of my colleagues, my nursing lead, and then the hospital management that we use in that is municipal hospital, we managed to set up the first intensive care unit to take the first few patients who were very ill. Immediately we set up that ICU, the same day, we had 2 patients arriving, very ill. The next day, we had another patient. It was 4-bed. We filled it within 3 days. We lost our first patient, and that was heartbreaking because this is a patient that had been in a private facility, but not yet diagnosed, and very ill, but was suspected. By the time he got to us, he was so very ill that we had to put him on life support, and we lost him within 48 hours. We knew then that we had a fight in our hands. There have been people who have been crazily ill. Our longest patient in our ICU has spent 39 days in the intensive care unit and survived, is perfectly back home now with the family. We've had patients who spent in excess of 30 days, and those who spent even more than almost 2 weeks before coming to us. We've unfortunately also lost some people, irrespective of how aggressively we had fought for their lives. In ICUs in Ghana, or critical care, since we eventually started our setting up critical care, we basically had probably getting towards almost about 300 patients who have been in critical care now. We've lost quite a number. Majority of those we have lost are those who didn't get a chance of getting into ICU because of the capacity limitations. We've been working feverishly, just came back from Kumasi yesterday. We were in the central region last week. We're going to Western region next week, trying to assist our colleagues to expand capacity and then to also help train. But it is real. It is very real. You
mentioned Kumasi, and I'd want us to stay with Kumasi for a while, in Ashanti region to be specific, because there have been concerns that Kumasi is recording an increasing number of deaths, and people are worried. They are asking, why is it that Kumasi is recording so many deaths?
All right, so let me be quite very plain about it. As your numbers go up, the number of the percentage of people who may be critically ill or severely ill may stay the same, but absolute numbers, because it is a percentage of the numbers that are escalating, will rockets, will go up. It happened to us in Accra, in Greater Accra region. So as the numbers keep going very high, the numbers are going to go up. Remember that we are not able to change the number of beds in our hospitals overnight, or the number of doctors, and especially doctors and nurses and other health practitioners who practice critical care overnight. These are structural changes that take some time. It means that we're stretching our health system very severely. It means we're putting huge strain on the personnel that are working. And I'll tell you, earlier on, we knew that Accra would have gone exactly the same way if we had not been able to open places like our East Municipal Hospital and able to take critically ill patient, or University of Ghana Medical Center, or Kolebu Teaching Hospital Medical ICU, or the LWAC high care area in by 37. So now you see me mention quite a number of places where we could manage the severely ill, in addition to even private places like Nyaho, Focus, Anima, and others that are coming on board, holding on to those patients and giving them at least some level of care to keep them alive until they get to us. Now, Kumasi has similar population to Accra, and their numbers are going up because a lot more people are spreading the virus. But they don't have as much facility as we have in Accra.
Okay, so it's an ICU. It's an ICU facility.
Yeah, the facility for the severe and critical, because they're the ones who are really dying. So as I speak now, they have expanded. They are doing basically more than 20 beds in Confanoche. The doctors, the nurses, they are working their hearts out, but their ICU and high care for COVID is full. So what that means is that if other facilities do not come on board, and other facilities coming on board, it's not just a structure. It is mainly personnel, trained personnel to do that. Now, so that's a problem. So it's not a peculiar situation with Kumasi. And I'm going to give you an example stepping out of our country, where our health system is nowhere as robust as it is in the United Kingdom. Emma, one of our colleagues, Emma, is in London, and the mortalities in London are way beyond what we've seen anywhere in Africa. There's over 40,000 people die in the United Kingdom, but they have crazy bigger facilities, a lot more technology, a lot more human resource. But when your system is stretched bare and you overwhelmed, you're going to lose people. And if you have a finite capacity that you can stretch to a limit, what it means is that you have to put every effort in making sure that you do not continue to spread the virus. If you continue to spread the virus, we'll get to that point where a lot more people are going to die.
Right. So, Dr. Owoo, in effect, what you're saying is that the more cases we have, the more severe and critical cases we're going to have on our hands, and the more deaths we're going to have.
It's as simple as that. Because when we can expand what we are doing. Yes, we can, and that is what we're doing at the moment. So over the last couple of days, we've been in to basically bring on board one more facility that should be able to give significant support to Confanoche. We've done similar with trainings and assessment we've done in the regional by the national case management team. But our resources, human resource and then material resource, are finite. We need to be able to control that. If not, more people eventually going to die. That's the frank truth about it.
I want to go to Dr. Emma in London to tell us what the situation is like at the end. No, Dr. Emma, now you have experienced the situation, or you have seen the situation firsthand in the UK. Is the UK, or the UK essentially has done quite well in flattening the curve, or going around the bend. What is the situation like now, and what are some of the instances you had to encounter?
So thank you for having me on. The situation now is actually much more improved than it was going back to March, April time. In my case, I was enlisted to work on the COVID ward pretty much the whole way through the peak, throughout the months of March and April. And what we saw were very high numbers of cases, and very similar to what Dr. Owoo said, in that we just didn't know exactly how this virus was going to behave. Every prediction that was made was, it was educated guesses, kind of, looking at trends from things like the flu, from things like SARS and MERS, those smaller epidemics that we've seen in years past. We really didn't know exactly what this virus was going to bring, but there were things that we did do, in that we did increase our intensive care capacity, you know, massively. And I mean that at a local level as well as a national level. Even had new hospitals built. So we had Nightingale Hospital, which was transformed from an old event center, created 1,000 more beds, 1,000 more ITU capacity. And at the moment now, cases have come right down. Now the hospital that I personally work in, we don't have, at one point, almost all the wards were converted into COVID wards. And we cancelled all our, you know, non-emergency things, all the non-emergency surgery and admissions. Everything became focused on COVID. And now, you know, the cases have gone right down. We don't have a dedicated COVID ward anymore. Of course, we're testing every patient that comes in the hospital, but there just aren't as many cases anymore. So I think we're definitely seeing so much more improvement. But of course, we know that we must remain vigilant because, you know, there's not only just this second wave that everybody's talking about, but we don't want to see cases go up at all. All
right. And at this point, I would want to go to Dr. APPIAH KUBI, who is in Hong Kong, one of the countries that's known to have handled COVID-19 extremely well. Dr. KUBI, what is it that Hong Kong has been able to do to handle this or manage this pandemic so well?
Well, Israel, thank you very much for having me. For Hong Kong, so far, first, let me give you the figures that we have for us at yesterday. As of yesterday, we have had 1,431 confirmed cases with
1,141 confirmed cases from
1,431 confirmed cases.
From day one?
But he's getting told. Yeah, from day one.
Okay.
And then we have had 1,176 recoveries with only 7 deaths.
Wow, now, that's impressive.
Yes, it is. To understand how Hong Kong has been, how Hong Kong has fought this virus, you should understand the historical perspective of infectious diseases in Hong Kong. You know, in March 2003, Hong Kong was hit with the severe acute respiratory syndrome, SARS, and they recorded about 1,755 cases with about 299 deaths. Okay, so now the aftermath of this epidemic, what they did was that they set up a SARS expert committee.
So when you take it, it does this, put it in water.
So the SARS expert committee, after sitting, came out with about 46 recommendations
down in the water
and fighting capabilities in the city. So what they did was that they did 46 recommendations, but because of time, I cannot go through all the 46 recommendations for you, but I'll give you the salient points they came out with. What they did was that they established the Center for Health Protection. That was supposed to more or less be the public health protection agency of the city. So they also improved on the quality of their medical supplies. And then they also improved on their facilities. They also trained staff that will have more knowledge on infectious disease control. And also they also built more isolation centers and then isolation wards across 14 public hospitals. Okay, so in effect, Hong Kong was already ready for such a problem. They have had a structure in place already waiting for something like this to occur. So as soon as it happened, from when we're entering the Chinese New Year, late January, we all heard about this virus coming from Wuhan in China. And you know that Hong Kong borders China. I mean, it's just next door. So the government said, okay, now this is happening. They quickly mobilized their health professionals. And the first thing they did was that everybody should put on their mask. And I'm telling you, Israel, it's a culture here. Everyone had to put on their mask, whether you are young or old. And one good thing here is that the compliance is excellent. When they said we should all put on our mask, everybody complied. Nobody was willing to challenge why I should put on a mask or something. And if you know the Asian culture, you know, they have this flu that cuts across this area when the weather becomes a little colder. So the mask is like already a culture where people try to prevent flu when they have they have flu infection. So the mask was a must for everybody, and so far we all comply. I never leave my place without my mask on. Okay. Now, so what they do was that they also moved quickly to seal the borders between China and Hong Kong.
Okay.
Yes, they quickly sealed the borders, even though people complained it was late. The people had to agitate a little for their government to close the border, but eventually they closed the border. And I believe that stopped a lot of the transmission coming in from mainland into Hong Kong. Now, what they also did was that when you come in from mainland or from the beginning, everybody was preventing people from coming from mainland. So when you come in from mainland, you are quickly tested. Nobody comes in without testing. So you are tested, and then if you test negative, you are sent home to self-quarantine for 14 days. Now, when you are going home, you are given a wristband that has a specific radius. So when you are home, you cannot even leave your house. I mean, when you cross that radius that the wristband prescribes, you are quickly called and the police will come after you to send you back home.
Just like that.
Exactly. So when you are home, you test negative and you are sent home. You quarantine for 14 days. After 14 days, you do the test again. If you are negative, you are allowed back into the community. Now, when you test positive, what they do is that you are quickly taken to the hospital by an ambulance. You are not allowed to mingle with the people. I mean, you can't take a taxi, you can't take the MTR, which is the public transit system. You can't take a bus, a public bus. You are taken to the hospital by an ambulance, and then you are seen, treated, and then if you get better, you are sent to the quarantine center to quarantine for 14 days. And at the quarantine center, you are tested 3 to 4 times before you are released. You are also tested again to make sure that you are negative for the virus before you go back into the community. So
Dr. APPIAH KUBI, so you're saying that Hong Kong will test you to be sure that you don't have the virus before you're released back into the community?
Of course, you can never go back into the community without testing. You have to be negative before you move back into the community.
What do you make of this WHO recommendation that when you don't necessarily need to test the person after 14 days?
Well, it's like, I'll be truthful with you. I have my own problems with the way WHO has handled this virus from the beginning, but well, it's not for me to say. But anyway, for Hong Kong, the testing is very important because of their past experience with SARS. They were very particular about this virus, and that is what has made them fight this virus up to this extent, because they were not prepared to let their guard down, to have casualties as before, as they experienced during the SARS period.
All right.
Okay, so testing is important. Now, in Hong Kong, you can test in any accident and an emergency in all the public hospitals. You can also test at the OPDs of all public hospitals. And even in private hospitals, test goes on in private hospitals. And as soon as...
That's great, Dr. APPIAH KUBI, but it's also Hong Kong has the resources. You're talking about the technology that was used, that they're giving you a wristband and you can go beyond setting. So it's the resources that you had available. I want to go to Dr. Emma in London to find out what they also make of these recoveries or the recommendations that were given by the WHO when it comes to recoveries and discharges. Dr. Emma, how do you handle it there?
Ours differed quite a lot. We are changing and almost a recommendation because of the capacity that we had and the ways in which the UK decided to handle the pandemic. I think what Dr. KUBI said is that Hong Kong had this previous experience with SARS, but the UK hasn't actually been through a respiratory pandemic before. Yeah. So the response was very, very different. Initially, I was working on the medical wards of patients who have COVID, who either did not need intensive care support or were not eligible for intensive care support, maybe because they're already elderly or frail. So a lot of just managing how we could on the ward and some survived and some didn't. With regards to those who survived, I know initially we were sending them back to nursing homes once they were 8 days after a positive swab, as long as, of course, they were clinically well enough to go. Later, we realized that 8 days was too short, and then that extended to 14 days. So it's quite harrowing to think about those that maybe we sent back to nursing homes too early. Did that mean that they went then nursing homes and spread the virus to all those around them? It's very harrowing to think of this, especially because later on in the pandemic, we then saw massive spikes of the virus in nursing homes, and we worried if we had made a similar mistake, because Italy had also done something similar, and we know that their numbers were through the roof. Later on, this changed, so we increased it to 14 days. Also, initially, we weren't re-swabbing patients because for a number of reasons. Firstly, there were some people who we initially tested for COVID with a swab, who had a negative swab, but quite obviously had COVID because they were behaving like they had COVID. The imaging of their chest showed that they had COVID. They just looked like COVID. So and for those who had a negative swab, it just felt that we can't put all our bets on this swab. It's obvious that this person has COVID, regardless of 1, 2, or 3 negative swabs. So we felt there was no point in re-swabbing people before sending them home. The second issue as well is that taking a week to get back the results from a swab. So we would swab people, we wouldn't get the results back from a week, and then even when we got the results back, we weren't sure if how much to rely on it. So we were going a lot by clinical basis, clinical examination, X-rays, CT scans, things like that can tell us how this person is behaving regardless of the test result. Right. So we weren't testing people to say, oh, your swab is now negative, that means you're safe, because it just wasn't true. And we also didn't want to be a case where we told people, you now have a negative swab, that means go home and be happy with your family, which would be just as dangerous. So it was, let's not swab you, we think you're better, but you need to go home and continue to isolate, because for all we know, you could still be transmitting the virus, even though you're feeling much better.
All right.
Strategy was very different. At the moment, we're relying much more heavily on swabs because the swabs are being turned around much more quickly. If I swab someone today, I'll get the results tomorrow.
All right.
Relying a lot more heavily. And secondly, there are so few cases now really in the local community. And I'm speaking particularly for London only. I know parts in the north of England have very high cases still. The community transmission is so low that we think, it's worth putting a bit more emphasis on the swab and ensuring that we're getting negative swabs before we send people home. So it's all varied quite differently, and it's required us to evaluate our local policies very often.
All right. Dr. Owoo has his hand raised, so I'd want to go to him. Dr. Owoo, you want to make an intervention?
Yeah, so thank you, Israel. I just wanted to contribute to that particular discussion because it's important to put things in context so that, and every country, every continent has had absolutely different context with respect to this pandemic. The same way that the pandemic did not arrive in every continent at the same time, lessons learned had been learned at different points in time, and people have generated their own data while they are having the pandemic in their own country. So it's always so very easy to say what could have been done better from hindsight, but nobody had hindsight. It started off in Asia. So of course, the Asian countries had a better awareness what was happening in China and whether this was going to, I mean, when it was in China, nobody expected it to be a pandemic. If anybody in Africa or in Europe says today that somewhere January, February,
are you okay?
That they knew that it was going to be a pandemic, then I'm not sure whether that person is being truthful. Now, other countries have also had different experiences, as Emma mentioned. Africa, a lot of the experience in Africa has been with more of hemorrhagic infectious diseases like Ebola and dengue and others, not as much with respiratory epidemics or pandemics. Now, it basically meant that nobody had run a budget in the beginning, at the end of last year, preparing for an epidemic in their country. Neither did Ghana have that. The health system, basically, we all knew was already problematic, and it wasn't going to change overnight. It basically means you had to repurpose things. By repurposing meant that you also are aware that your caseload or your disease load from other conditions did not just suddenly disappear. It has meant that we probably have also had excess deaths from other conditions that were putting burden on our health system. So at the time this arrived in Europe and Africa, and of course, Northern America, we all knew that at that point, and it was even difficult to get personal protective devices. Yeah. China was at the height of it, and most of these items were coming from Asia. We started off with inability to even get the face masks, both the N95s, FFPs, and all that, because of course China had an epidemic, and they were not exporting to any country, absolutely not to Africa at that point in time. It basically meant that you had to draw up your plan based on your country experience. Yeah. By the end of April, May, we were quite aware how long it was taking us for our patients to recover from COVID. And we knew that it was between 10 to 14 days. WHO has had its challenges, but I wouldn't bastardize WHO. There's absolutely no country in this world which will tell me that they have handled this perfectly. Every country has had their difficulties. US has had difficulty. UK has had difficulty. They all have strong health systems. WHO had to bring those information from different places to try to make a decision in a crisis environment. I think it is wrong to bastardize such an associate organization. But what we should be aware is that it is these information that people are getting in their national context or in their regional context that fits in. Ghana, we did not adopt that from the very beginning, but when we knew we could document how long it was taking for people to recover, we knew that over 95 to 98% of our patients were seroconverting or changing to negative between 10 to 14 days. Then we could say that after your symptoms has resolved, or if you were asymptomatic, 14 days after. And that's what public health really is about, to learn from what you're experiencing and impute that to how you manage, especially in a crisis. And I think UK had similar, US is having similar. Every country is going to have an experience. They are going to use the lessons they learned from that experience to guide their guidelines to be able to respond. Those who had previous experience with respiratory illnesses had better experience and better preparedness. They probably had already built such systems previously, and they could activate that on short notice. We didn't have some of those to activate. We had to build them de novo. You can't train an ICU expert in 2 to 3 months. It takes 3 years to train fellowship in critical care. It takes 2 years to train nursing critical care fellowship. Yes, you can improve people's knowledge to manage, but you can say that these are things that I was expecting would happen in 2020, and therefore my system was ready for that. So that's the context I want us to understand. So
thank you very much.
Yeah.
All right. Thank you very much, Dr. Owoo. Now, this conversation really, I intended to have a conversation where we all are going to come up with ideas as to how we can stay protected, stay safe, so that we don't get COVID-19. Because as we have heard from the doctors and the survivor, Nana Tima, it can get really bad when you get the virus. So I'm going to make it open to everybody. I want you to come up with suggestions, especially those of us in Ghana, how we're going about staying protected or staying safe, and how we can make it better. So I want to start with myself. I keep my nose mask on virtually all the time. Immediately have to leave the house, I make sure that I have my nose mask. Now, if I get out of the car, I'm putting on the nose mask before getting out of the car. After doing whatever I have to do, I come back into the car. I sanitize my hands first before I actually take off my nose mask. And I have an N95, and I just put it on the dashboard, because my understanding is that all you need is for the sun to hit at it. And so I leave it on the dashboard whilst I'm driving. The sun is, the sun is hitting at it. And when I get home, it's parked out and the sun is still hitting at it. This is what I'm doing. I may be doing something wrong. If I am, I'm expecting that you, the doctors and the frontline health workers, can advise. And that advice goes to everybody else who's also watching and joining the stream. So I want to start with Dr. Addae. You haven't spoken yet. So Dr. Addae works with Dr.
Hello, Israel, and thanks for having me on board. So I've listened to all that has been said. I think essentially most of our sentiments are the same about how the since it hit this country up to this point. When it comes to precautions or things that we can do to try to mitigate the spread, I would first want to emphasize the hand washing. That's where I want to start from. I want to emphasize hand washing. I want to emphasize thorough and frequent hand washing. I think we need to get to a point where the hand washing becomes part and parcel of us. As in, even, I think we have to get to a point where hand washing comes to us as naturally as holding or talking about phones. And I think one of the ways to inculcate that habit, start from our home. Make sure on a family level, we all come from smaller units, family units. So if we start on the family level and every family or every unit makes it a point to ensure that every member, adults, children, everybody is washing their hands thoroughly. Because in Africa, in Ghana, previously hand washing culture, there are people who wouldn't wash their hands before they eat. They would wash their hands after. A whole lot of myths go around with hand washing. So COVID and all this emphasis on hand washing, it's kind of difficult for people to do or to remember to do frequently now. But it needs to become second nature. Emphasize it also in our schools, add it to the curriculum at an early age. Because I know this hand washing is taught to children in school, so that by the time they grow up, it's already part and parcel of them. Because we've all learned that if we wash our hands frequently, it increases the chances of picking up the virus and then transmitting it. So the first thing I will say is we should all make the part and parcel of us and teach people. Next thing I want to stress is the social distance or the physical distance. That's also very difficult because in Ghana, it's not our culture. We are people who like to interact, to hug, to shake hands. So this is actually very difficult for us to do. And as much as environment is good, I think a lot of it people decide or naturally tend towards adopting the constantly having so it can become culture, just like we have this culture of greeting. If we can learn to keep that distance, I think it will go a very long way to help us all. So that one, it's about us being each other's keeper, because that's what that is. It's not easy for children, for adults. We all know it's not easy at all.
All right.
So we just have to be keeper.
Now let me go to Dr.
Those are my first two suggestions.
All right, I'll go to Dr. Oliver Kome. I was in Accra Central at some point in time. I had to go and buy something at Accra Central. And I was looking at the crowd at Mokola and the people mingling. It's very difficult in such a situation to say you're social distancing. How do you go about it? And if you happen to have gone through Mokola, what do you do when you get back home? I mean, you can wash your hands, but the virus could have, running onto your clothes or something. How do you, and of course, there were people too who were not wearing the nose mask, and there were people too who had dropped the nose mask and it was under their chin. Dr. Oliver Kome, what do you have to tell such people, and what do we do when we find ourselves in such environments and get back home?
Okay, like you said, we all need to protect ourselves. The recommendation is that anytime you're stepping out of your house into a place where physical distancing could be a problem, you need to wear your mask. We acknowledge that you can't go into the marketplace and maintain physical distancing. So the first thing is protect your nose, protect your mouth. As soon as you get home, first thing you do is if you have a chlorine bath at home, you can step in that chlorine bath, or a mat just soaked with bleach. You can step on that one just to clean your feet. And then you can head straight into your bathroom and take a good bath, a good shower. Wash your hands very well. In that case, if you are thinking the virus is stuck onto your clothes or the virus is stuck onto your skin, you would have washed that one off. If you had your mask in place, you would have protected your nose, you would have protected your mouth. Those are the things I think we should all do. We cannot run away from mingling with other people. But if you have to go anywhere where you are not too sure of the people around you, first protect yourself. Then you can say that others should also protect themselves. I believe we should all take personal responsibility first. Then we can encourage our brothers also and our sisters to protect themselves.
All right, thank you very much, Dr. Oliver Kome. Now, we have some comments coming on YouTube. I'd just like to read them, go through them quickly. Isaac Dati says, please, can anyone that has been healed from COVID-19 be infected again? The last time I checked on that, they couldn't tell me. Richard Dodu says, please, want to find out that if you have been infected by the COVID and you have been recovered, is it possible to get it again for the second time? The same question. Richard Quiz says, hi, Dr. Owoo, okay, not quite clear. While you await, what do you do while you wait your results, especially when you're a health worker and family man? So I'd want to go to you, Dr. Owoo. Take the first three questions.
All right, thank you, Israel. Okay, so the first question was basically whether somebody who's been infected can be reinfected if it's recovered from COVID-19. Yes. We do not have any evidence at the moment to suggest or support that. We've actually on our own also, and I think a lot of countries has been trying to look at the data to see whether that is possible, and therefore to decide what to go about it. Now, again, we are just basically 6 months into this pandemic for the whole world. There's a lot we still do not know. I knew there were papers that came out from Spain just recently talking about whether they are finding antibodies, which are basically the things that fight your infection when you get an infection, and sometimes they linger on for years if you have prolonged immunity. And they are suggesting that after 3 months, they are finding antibodies just in about 5 to 10% of the people that they have looked at. It's a small data. What it means is basically, would there be another wave of COVID-19 if people are getting it at different times and therefore can be reinfected? We don't know. we are trying to be careful, cautious. What we are saying is that even if you've had COVID before and recovered, that you should still continue to wear your mask now. And that is where the issues about testing. There are people who are just going, asking to be tested with absolutely no reason or no indication for testing. And then you're asking, what do I do with that person? That is different from a group of people where we say that you have been exposed to somebody who tested positive, and therefore we say that you are a primary contact. When we say we're a primary contact, we test you to find out whether you have been infected. Now, when we take that test, sometimes the test may take a day, two, or sometimes even longer, depending on the backlog at the testing laboratories. Whenever you're tested because you're a primary contact, you are supposed to quarantine. What that means is that, and I use the term quarantine because it's different terminology from isolation, but it means to do the similar thing as we do with isolation. But you will use the term quarantine when you have not tested positive, when you are a suspect, and we use the term isolation when you have been proven to be positive. So we ask that if you're a contact of somebody who has tested positive, and for that reason, you are being investigated, you can't be walking about if you're a health professional, because if you can't have positive, you would have actually increased your own contact with people who you've had been in contact with, and those people will now have to be tested. And if they also do not quarantine themselves, that is actually part of the reason why we are having a very rapid spread in the community. Yes.
All right, so we are taking some more ideas as to how you believe that we can all stay protected from COVID-19. If you have a suggestion, just raise your hand and I'll bring you into the conversation. But this conversation, this is just the first in the series. I want us to keep doing this every week. So Sunday, when you're back from church and you are at home relaxing with the family, I want us to have this conversation. And I want this conversation on social media because I believe that's where we have the critical mass and it's easier to reach. You don't need to have a TV to get to see what's happening on Facebook Live. And I must say, I must apologize. I currently lost the feed on Facebook. For the feed is now back on Facebook. I have one hand raised now. Twinkle. Okay, so Twinkle, you can go ahead.
So sorry, Israel. Twinkle is actually Nana Tima again.
Nana Tima.
Yes. So when I think Dr. Kome, when he said about the precautions, he said when you are going to a place where you are not the people, you need to put on your. And from what I read from Facebook, that is actually where I think one of the places which makes it quite murky and which is making the virus spread very much in workplaces, because in my office, I have an office to myself. When anybody is coming in, you're required to wear a mask. And I don't have more than 2 people in my office at a time. But with my colleagues, now on hindsight, I realized there was a lot of laxity because we are used to each other. And I'm thinking, oh, this is Agnes, this is Alberta, this is my boss. I mean, we're sharing lunch and we're having conversations and we're sitting in the same car. So they couldn't possibly have the virus. And that is why one person contracted the virus in the office. Literally, if anybody listened to my boss's interview on Peace FM on Friday, said that if you test 50 people, 5 persons were positive. Most of us tested positive because there was a lot of laxity within us. When I was going to Kumasi for the primaries, I was very cautious. I had my mask on, I had my shield on. I made sure there was space between me and people all the time. I made sure I wasn't in a crowd. But in the evening, when it was just us, and when I say just us, when it was just our team, nobody had a mask on. We weren't washing our hands as frequently. So I think that is one thing that we pay attention to. And I was jokingly telling people this. Somebody's serious girlfriend is somebody's side chick. So the person that you think is, I mean, this is my colleague that I'm in the office with, and he couldn't possibly have the virus. You don't know where that person has been. So at any point in time, now when I step out, since after the virus, when I step out, I'm consciously looking at people, and it's registering more the mistakes that we're making.
Yeah.
Because you're handing on money to someone, the person is not sanitized, the person has received, they put it in his pocket, he's wiping sweat off his face, his nose is twitching, and so he's rubbing it. And you realize that subconsciously people are making so many mistakes. So I think that the precaution, the care has to start from our homes and our offices. Of course, I cannot socially distance from my husband, but I need to make sure that I'm washing their hands more frequently. My cousin who's helping me watch them is washing her hands more frequently. She's sanitizing. We're upping up. We're building up our immune system. When I return to the office, I'm making sure that, you see, nobody has their status rating on their forehead. No. So anybody that I interact with, in my mind, at the back of my mind, you have the virus. Right. And so I make sure I do not get it from you. And it would also help if everyone thinks that I have the virus, and so they're not coming too close to me. They are wearing their mask. I'm wearing my mask. We're sanitized. Touch a surface, we are sanitized. And then I guess it would help. We'll be fine. Like when I was talking initially, I said for my mother, because she sells in the market and she's had some education, she sees first, and then she tells me that because she has a mask on all the time, people think or trend home, because I mean, this is Kumasi Central Market. Everybody who even have the mask on, they're wearing it on their chin. So why does she insist on having it on her nose? And she insists that, you know, my grandmother is 83 and she lives with my mother. My mother may survive the virus. My grandmother may not, even though there isn't the 100%. Yeah. So she makes sure that my grandmother doesn't catch the virus, you know. So we just need, so when even I went to Kumasi for the primaries, I didn't go home because of my grandmother. Because I saw if I catch the virus, I wouldn't want to pass it on to her and all of that. So we need to start being cautious from home, from our inner circle. I'm watching videos of people attending parties, attending funerals, and there's total disregard for the protocols, because I mean, this is just my inner circle. This is my core team. You don't know where the other person had. So please, there's no, the virus is no respecter of persons. The virus will say that this person is your friend, so he or she won't get it. Let's be cautious from within, and I'm sure that we'll be fine.
All right, so I have a few hands up. I have Patrick's hand up. I also see Dr. Addae's hand, and then Dr. Owoo. I'll go to Patrick first. Hello, Patrick.
Hello, Israel. This is Dr. Aboagye.
Hey, Doc. Thank you for joining us.
Yes, I've been on for a while.
Okay.
And I think it's been a brilliant discussion, and I think it's very, very helpful. My only comment is for us to look at the long-term effects. I listened to the Hong Kong issue, and I think something we can learn a lot. We need to look at our systems. We have to build capacity, institutional arrangements in our workplaces. The previous speaker, you cannot be cautious all the time, but we need to put in system. We've had conditions like H1N1, which requires the same level of care. But as soon as it's over, we stop washing our hands, we stop wearing masks.
But it's we both were coughing.
Hello?
I think that my attack was triggered there.
Hello?
Oh yeah, Doc, can we have Dr. Patrick Aboagye on now?
Yes.
Let's let him speak.
And so we need to...
you have to mute, Ivan, your microphone. Ivan, mute your microphone so Dr. Aboagye can speak.
So, Israel, we need to look at our institutional arrangements. How is our office setting helping us avoid infections?
All right.
How is our building code being done in a way that protects all that? How are some of our laws, not just short laws, but laws that help us to, in the long run, be able to fight this? Because most of the diseases are going to come up. We're going to come up with the same respiratory conditions. And like you said, the Asians have had their experience, and so compliance is better. But we need to institutionalize some of these arrangements, especially at the workplace, and then ensure that we are able to really fight this disease. Because the disease, the control is not so much of what the public health measures are on the treatment, but our own behavior change. That is extremely important. We need to look at our building code. We need to look at all our laws and make sure that these things are avoided. And also in the health sector, as we are doing, building capacity, just like in Hong Kong. And that's why you are seeing a lot of infrastructure come up. Because in the last 10 years, we've had about a third scare. Right. And for this one, the two were scared. The SARS didn't come, H1N1 came, Ebola didn't come. But COVID-19 is here. You don't know which one is going to come. But they all require the same level of measures to prevent infection. And so I think we need to start looking at that long term and change our system to be able to be better prepared, just like Hong Kong was when another one comes, or if there's a second wave or whatever.
Dr. Aboagye, now that we have you on, there is a few questions, or a few nagging questions. It has to do with the decision or the way the Ghana Health Service talks about recoveries and discharge. We have recoveries / discharge. And I feel that when we do that, well, a lot of people have come up to say that this is quite confusing because we have discharges, and in some cases, or in many cases, correct me if I'm wrong, these discharges are people who probably haven't even been to the hospital, and so, or treatment centers. So when you say discharge, then people get the impression, oh, we have so many recoveries, and this disease is not so scary after all. And so, yes, let me go about my business. I'll be discharged anyway, or I'll recover anyway. How do you respond to that?
Yeah, thank you. See, if you assume discharge is only from the hospital, that's when you start thinking that way. When you are positive,
people are actually doing that.
Yes, but when you are, I want to make sure that even when you are at home, you are somehow under our care. If you are positive, you are either, if you are sick, you are in a treatment center. If you are asymptomatic, you are in an isolation center. If you are asymptomatic without comorbidity, and you have a place that we are certified can self-isolate, you'll be there. So you are still under our care. You follow it up, etc. So when you are better, you are off, you are no more infectious, you are healthy, you are still discharged. Either you are discharged from the follow-up, discharged from isolation center, or discharged from a treatment center. And that is why the discharge is important, because even though you are home, you are still under our care. And Dr. Owoo and Dr. Kuma will tell you the number of who they have to call and follow up and make sure they are okay every day. So it's still that group that we call as discharge. Someone could be discharged from COVID, but he's had his diabetes not under control. He might still be in the hospital, but he'll still be described as discharged from COVID, whilst the person may still be in the hospital. So that's exactly what it is. So even for those who are at home, we're still under our care, and so we'll discharge you and stop the follow-up with you.
Do we still want to lump the two together and say recoveries / discharge?
You see, we've had the two all the time until we change the approach. And so we want to ensure that people know that if you're at home, you are not on your own. You are still under our care. So when we discharge you, they will call you and say, okay, after these 14 days, you're okay now, go back to work, etc. So it's still a discharge, a form discharge. And I think the media can help us explain to people that discharge doesn't mean that you are in confinement and you have been released. No. Even if you are home and in isolation, you are still in confinement.
Again, then it also means that the fact that you belong to the discharge recovery category does not necessarily mean that, so if we have 19,000 discharge recovered, it doesn't mean that all 19,000 can't spread the virus.
No, they can't spread the virus. The
Are you
discharge
saying
is
that
primarily...
the 19,000 can't spread the virus?
No. Primarily the 14 days is that we know that from many of studies, including Ghana one, 11 to 14 days, you may even test positive, but your ability to spread the virus is 0.
All right, now there are instances where somebody has been told of their results and they are not in hospital. You're saying that that person still can't spread the virus?
No, he's in home isolation.
So home isolation, will that still be counted as discharge recovered?
Yes, if you do the 14 days, you are in home because you are still under our care in your home, and we follow you up. So once we say you are discharged, it means that nobody's going to follow you up again unless you develop a different condition. So that's what, or it may ask to come for some follow-up a week or two later. But we classify the three as a group of people who are in care, home, in the institutional isolation, or in the treatment center. And so they are all group of people who are within care that we can discharge from the home, and we don't have to follow it again.
Are there people who are in home isolation but who can spread the virus?
Well, if you are on isolation, it means that you can spread the virus.
But we call them discharged and recovered.
No. After 14 days, and you don't show any symptoms here, that's when we say you have been discharged. That we know that you cannot spread. And that's why those in hospital and those institutional are kept in, say, PCC, etc., are discharged home, because that discharge purely means that you cannot spread to anybody else.
All right, Dr. Aboagye, I'd love that you continue to stay on, but I want to go to I want to go to some other people. Dr. Owoo,
yeah,
did you have a comment to make?
Yes, so I just wanted to add to what my boss was talking about, Dr. Aboagye. So because that clarity needs to be, everybody needs to understand that clarity. If we say somebody is on isolation, that isolation can be at home. It can be in a place where we have institutionally isolated people, but they are not very ill to require hospital. And we've done that in hotels, we've done that in hostels, we've done that in places like the Pentecost Convention Center, Isolation Center. And then, of course, the patient could be in isolation in a treatment center because they require medical treatments. Now, all patients on isolation during the period of where they have not been discharged from COVID-19 can infect other people. That's why we isolate them. Remember, I said earlier on that the different word, if you have not been tested positive, is quarantine. Because if you have not been confirmed and we've taken a test and we suspect you, you could be positive, you could be negative. So even that person can infect somebody. So everybody on isolation can infect somebody. And that's the difficulty we have when people who are on home isolation decide to move about and do not also follow protocols. So that is wrong. So if the person is on home isolation, it means that the person, similar to our patients who are in treatment centers in hospital, are not allowed the freedom to go about everywhere, okay? And of course, they, even when they are in isolation, they still have to obey the protocols with hygiene, social and physical distancing, and in themselves. Now, we say that after a period of time, based on our data and other data from other places, and including WHO, for our current knowledge, we know that between 11 to 14 days, people lose their ability to pass on that infection to other people. And again, let me say clearly, based on current evidence that we have, that ability to pass on that infection to other people for those who are asymptomatic, and then if they are not able to pass it on, and that's when we say that you are discharged. So when we use the term discharge, if you are on home isolation, you will be discharged. So what I say at the point where we say you are discharged means that we are saying that based on our evidence and our knowledge at the moment, you cannot spread that infection to somebody else. You could be in hospital. We would also say that you are discharged from COVID-19. Okay, you could be in a hotel. We would say that you are discharged from COVID-19. What we are saying is that you cannot spread that infection. The difference between that and recovery for the terminology we use now is that you could be discharged but not well enough to go home, because recovery for disease conditions is not only based on laboratory tests, it's also based on clinical recovery. So you can, because COVID, for those who are severely ill, like the patient who come to my ICU, at some point in time, they may test negative, but because of the distraction of the infection on their lungs, on their heart, on their liver, they may still be require ICU or require hospitalization. So although they may have been discharged from COVID infection because they are no longer having the virus, they are not covered from the consequence of that infection. So it is when they recover from that consequence that we can really say that they have recovered. Do you get the difference?
Okay.
So everybody who we are saying discharge means that we are basically saying that on current evidence that the ability to pass that infection, the virus from one person to the other, you've lost that ability. But let me add something, that this is for those we have tested and we know that they are positive. There are a lot more people who are in the community who have not been tested, and either because they do not have symptoms, they didn't come to hospital, they may be in the community. So we may have a lower number of active cases based on our laboratory testing, but we are not running away to say that the amount of infection in the community is definitely that lower number.
All right.
That's why we are very careful in saying that please obey those protocols. Even if nobody has ever tested you, there are communities where we know that they may be endemic, but we don't test you just because we want to test everybody. We did that initially for some of those places where we did the enhanced testing, but that is logistic nightmare. It also affects our ability to treat because then it creates a backlog of testing, affects the treatment centers. So we may not be doing enhanced testing in a lot of places because it is a lot of resources to do. But we say consider the next person that bypasses you, even if you have no symptoms, as having COVID. And therefore, hygiene, social physical distancing, and masking are extremely important in protecting you and also in protecting the person from you.
All right. This point that you've made is the same point has been made by a few others who are joining or who are on this Zoom conference webinar. They're saying that assume that everybody that you're encountering has COVID. So just observe the protocols. Wear your nose mask, wear your face mask, social distance, and don't interact when you don't have to. There's a question that's come through for Dr. Patrick Aboagye. Now, Dr. Patrick Aboagye, is it possible that someone would still test positive for COVID-19 after 14 days? And if that is the situation, can we still say that after 14 days, everybody has recovered?
Yeah, basically what we are saying is that we've also found out that about 0.7% of the people will continue testing positive. And it's usually as a result of, most of the time, we discovered dead viruses that are creating that persistent positivity. So as Dr. Owoo said, under the current test, we've not been able to grow any virus after 11 days. So we assume that will remain. But testing and research continues. But from current evidence, we don't think that is the case.
Right.
Even for those who are testing positive, we realized that there were dead debris of the virus that was creating that positivity from the PCR test.
All right. Dr. Aboagye, your video is off, and it's important for the next question that I have for you. What to do with the statement that we've seen, or a letter that we've seen making the rounds, that some of the has been cleared, essentially, and then we have 2 negative PCR tests. It comes at a point when we have been told by you that you're no longer doing negative PCR tests. So why do we have that letter going on?
Thank you. I think we are actually looking at the circumstances. Under the previous regime, we had a template that was given to people who tested double negative because some needed back to their offices, etc. But I'm going to follow up and see whether it was on that basis that someone used an old template to offer that. So we are looking at how it happens. Now we have a template there that goes out there that are given to quarantine, and then other people who may need it for their offices or their workplaces to sort of alleviate the pressure that are you really negative. And so we are investigating to see whether this is under those circumstances one of the district directors may have issued that for them.
Essentially, you're saying that you haven't authorized the issuance of any circular.
We have a system in place where for those who did that in the initial phase, they were getting that for those who required it. So we are investigating to see whether someone used the template under that circumstance. Okay.
All right. Thank you very much, Dr. Patrick. We're still talking about how we can keep ourselves safe from COVID-19. This conversation, as I indicated earlier, we're going to be having this conversation every week. So every Sunday, we want to gather and have this conversation. We're looking for best practices as well. So what are some of the things that other countries are doing? And it's going to cut across all spheres of life. So we're looking at the workplace as well. There are things that some countries are doing. So some people in some countries are doing at the workplace to ensure that they're keeping themselves safe. Are there things that some people are doing at the markets to ensure that they are safe? Whatever anybody is doing in school, for instance, because in recent times we've had a big issue with people, the schools reopening for the final year students, and we've had a number of cases that have come up, and people are saying that we shut down the school. But there are those who are also saying that we can't really bring life to a halt. We must allow life to continue, despite COVID, which is the reason why we're having this conversation. How can we live with COVID? How can we survive with the virus? And so I'll go to Nana Tima, who is a survivor, and so that she's going to tell us what she is doing now, having survived COVID. What's she doing now to ensure that she doesn't get COVID again? Because we don't have, as the doctors have indicated, there's no research or saying to us if you've gotten COVID, you're not going to get COVID again. So Nana Tima, what is it that you're doing, which you want us to know about?
Okay, so Israel, I think I've already spoken about the extra precaution and how my mind is now very alert, observing the protocols. Having gone through, it's not really, now it's not about me only. I'm just going to be more annoyed because I'm going to ensure that those around me, those I'm in contact with, I'm just going to do more advocacy because I'm careful and I won't might get and pass it to a friend or a brother or a cousin who and let people learn to protect themselves better. I think one thing that I also need to talk about is eating well and build system. Unfortunately, I have a pre-existing autoimmune condition already, so my system is kind of messed up before this point. And so people, because when from a layperson's point of view, when I look at my had the virus, those who took it really well, who are always exercising and not in the gym, but then who are always exercising but quite sedate and then exercising like me. We had treat badly, so people need more. That's a question for the doctors. Even though I'm supposed to have it, I still feel very tired. So I've been sitting for this, and now I'm literally kind of like journey. Previously wasn't me. Another doctor said it's probably because I've not the house, not what I usually do, has also slowed down. I want to, and when will I feel 100% again? When will I not feel tired after 6 an hour and a half?
Right. Now, I'm coming to you, Dr. Addae. The question I want to ask and what I want you to speak to is the fact that a lot of people feel that if I've had COVID recovered, then that's great and I'm fine, I can go about my business. And so it's not probably that dreadful. But we've heard the story of COVID-19 survivors who say that, yes, you survive COVID, but there's so much that's done to your body, the organs in your body, which means that, or which you probably would have to be visiting the hospital even after you have survived COVID. Before you get to answer that question, please, can I kindly have all of you mute your microphones if you're not speaking, and unmute it when you're going to speak, because what we're getting is a lot of interference from those of you. There's some disturbance coming from you. Mute your microphones until you're ready to speak. There's a lot of disturbance.
Hello, boss.
Okay, can I have Dr.
Oh, okay, I have. Hey, I thought it was muted. Let me just go. Boss, I'm looking for it, please.
All right, it looks like
Yes, I can hear you. Can you hear me, Israel?
Yes, we can hear you now.
Okay. Yes, so to answer your question, I think a lot has been said, and clearly this whole issue of COVID is not just about a virus coming in and leaving your body and leaving you exactly the way you were before you had the infection. I mean, even aside the medical effect or the complications that one can get from COVID itself, like effect to the lungs and sometimes other organs, the heart, the kidney, the brain, and all that. So, and knowing the fact that some of these effects can even be long-term and can recover acutely, but have some residual long-term challenges. But all that aside, there's also the psychological aspects of this. You know, dealing with having the COVID itself, I'm sure the survivors will tell you the whole experience is traumatic. In Ghana here, we've spoken a lot about stigmatization too. There's already a lot of stigma associated with having the virus, and then if you have it and you have symptoms and you come to the hospital and in some cases even become critical, all that you go through, the trauma and the experience and the effect, you can recover to a point. And when I say recover to a point, I mean become free of the very acute symptoms that kept you in the hospital. And as recovery has been explained, maybe at some point even be discharged to go home. But sometimes, even after you go home, you still don't feel 100%. I think that is what one of the panelists was saying a short while ago about still feeling tired, and some go home and still have a few symptoms here and there. It may not be as severe as it was when they were in hospital or in the treatment centers. But again, the virus is still evolving. We still don't know everything about it. I'm sure going forward, there'll be more studies on survivors post-COVID for maybe the effect on their system for months and years, etc. And then we can come up with more figures and more data to say exactly the extent of long-term effect on certain organs. So what I want to say to everybody is, don't look at this as a headache, a mild headache that came and left, and everything is back to normal. As we have said, even when you are deemed to have recovered or you are discharged, still consider yourself as equally vulnerable as the whole population So consider yourself as somebody who needs to take extra care and who needs your immune system to be reboosted or rebooted to come up and put you in a better form to fight not even just COVID, but other conditions that may come up going forward. So the key word is that we should not get complacent at any point. If you've never had the virus, don't be complacent. If you have had it and recovered, do not be complacent. If you have had it and are still recovering, do not be complacent. We need to take each day, be more careful as we go on. For somebody who has we take more precautions and take your health generally more seriously. As in, the least symptoms you have, you should report it. You shouldn't take things for granted and say, oh, this one is just a mild cough, I've seen worse, or this is just a mild itchy throat, I've seen worse. It is very, very important. So I like the question that you asked, because we can't relax. We can't relax till we have all the answers, and we do not have all the answers when it comes to COVID.
All right. I want to go to Dr. Emma Amoafo-Mensah in London for her to also tell us what the experience is like. So you get to see the CT scans and the scans of the organs of patients who have survived COVID. Does recovery necessarily mean that you have a clean bill of health and everything is fine with you?
No, definitely not. Just to build on what Dr. Emma said, the key is to not be complacent. I think probably a few weeks ahead of Ghana, and I remember, I think towards the end of April, when we admitted our first patient who has had COVID, had been discharged and has come back still unable to breathe, and we diagnosed him with COVID-induced lung fibrosis, which means that his lungs are now very scarred. And this is a condition that he'll have for the rest of his life, and he'll be on various medications. Another thing we saw a lot is people with COVID were getting blood clots in their lungs and other parts of their body. So again, those people will have to be on tablets for months now to treat the blood clots. I've even seen COVID-induced diabetes, which I'm still a bit skeptical about, but the endocrinologists were sure that it was COVID-induced diabetes. And some of my professors are doing research into the gut effects of COVID, people that will have long-term problems with their digestion because of COVID. My personal opinion is that COVID may end up becoming something similar to tuberculosis, where we know that it primarily affects the lungs, but actually causes problems all over the body. But of course, we'll have to wait for the studies for confirmation of that. So I definitely want to stress, again, what Dr. Emma was saying is that COVID is proving itself to be a multi-system disease in that it does affect people psychologically. It affects their heart, it affects their, their gut, their digestion, and there's even rashes that people are attributing to COVID. So we're seeing that it shouldn't just be, oh, my breathing's okay, so I must be okay. No, your breathing may have recovered, but I think there is definitely evidence that other organs are being affected. And because of the way in which science works, we may not have the confirmation and all the evidence and the studies that we require to be able to, define these as certain illnesses. But I believe they will come, over the next few months and the next few years. And what we don't want is that, years later we're saying, oh, well, this person now has COVID-induced fibrosis, but they took it so, they were so nonchalant about it that we could have avoided it if we just emphasize the seriousness a bit more. So I don't think we should look at COVID how we've looked at some pandemics where we dealt with it maybe 6 months later, we're moving on. I think we're going to see the effects of COVID for years and years to come. I've personally discharged patients home with oxygen, meaning that they're going to be on oxygen for the rest of their lives now. When they came in, they were fit and healthy and going about their day as normal, but they're now going to be on oxygen for the rest of their days. So I think it is a very serious illness. We've got lots of recoveries, but we've also had lots of complications. And I think we'll be learning more and more about these complications over the next few months and years. And I just want to emphasize as well what Dr. Tima said about the psychological effects. So true. People have had real psychological issues, especially those that have been to intensive care. When they've come out of intensive care, they feel like new people and to now rebuild themselves back up to the person that they were before is a big feat. So we definitely should look at COVID as a multi-system disease, take it very seriously, because it doesn't just affect the lungs.
All right. I'll go to Dr. APPIAH KUBI in Hong Kong. Dr. APPIAH KUBI, what has been your experience with patients who have recovered from COVID?
Israel, for Hong Kong, I have been listening to some of my senior colleagues, and with regard to the isolation and the discharge of patients. For Hong Kong, before you go into isolation, you might have come into contact with a positive person and tested negative for you to go home on home isolation. Once you test positive, you go into a government quarantine center. Now, for some of these patients that have gone to the who tested positive and went to government quarantine center, like I said, you go through all the test process, the PCR test before you are discharged. And some of my colleagues have said, they continue treatment, because you know that we don't have a specific treatment for this particular virus. So we do the adjunct treatment. So like somebody said, somebody discharged somebody on oxygen, you go home with some drugs that will prevent black clotting. So as time goes on, they come in 2 weekly or 3 weekly, depending on how your case was for checkups and follow-ups. So basically, they try to keep on looking at the patients, and there are other research also going on post-COVID problem that will come up with regards to patients that recover from COVID-19. Now, again, like you said, for Hong Kong, we are looking at very good preventive measures. So there are guidelines covering every aspect of life here in Hong Kong. We have guidelines that covers the normal general guidelines that the WHO has issued that we all follow. Aside that, we have guidelines that covers travelers and returnees. I mean, those who are traveling outside from Hong Kong and those who are coming into Hong Kong. As I speak, they only admit people who are Hong Kong residents, those who live here. If you don't have a Hong Kong ID card, you are not allowed to enter the city. We also have guidelines for health professionals only, and even under that, there are different guidelines covering different places. We have guidelines that covers only infection prevention and control. We have guidelines that covers even the wearing of PPEs. There are guidelines that covers it separately, because you can have during emergency settings, you can have patients coming at OPD or at the accident and emergency, and you can have patients that are positive and on admission. All these places, you wear different PPEs to see those people. We even have guidelines for Chinese medical hospitals alone. We know we have Chinese traditional medicine. So there are guidelines that covers those hospitals. There are guidelines that covers allied health professionals who come in, those who come to do the X-ray, the sonographers, the medical laboratory scientists. We have guidelines that covers them. Then we have guidelines for even institutions and schools. So institutions like elderly homes, caregiving homes, there are guidelines, separate guidelines for them. We have guidelines for even residential institutions. And even there are some people, Hong Kong is a rich place. So there are some people who want to be taken care of at home. So there are guidelines for people who want home care, who are positive and want to stay home, and then the nurses will go there to care for them. So there are guidelines for that. Okay. There are even guidelines for workplaces too. And then even parks, cabin crew, even religious assembly. So for here, prevention is the most important thing here, to make sure that the cases are decreased as much as possible.
All right. I like the bit you talk about the guidelines and the guidelines for the various places, the workplace, the schools and all that. It's something that I'd want us to visit sometime next week. And I'd want to ask everybody who is on now to share with us what you think, the areas you think we should focus on in the coming weeks. I think one of the places you should be looking at is workplace, and why it is important and what we're supposed to do in the workplace to ensure that we stop the spread and we don't catch the virus because we've gone to work. So that's one of the places for me. I think the other place that's of immense interest is the schools, the school setting as well. Now, Dr. Patrick Aboagye,
Israel, before you go on, let me chip in something small before Dr. Aboagye comes in.
All right.
There's something I've observed back home. and I have been a little worried about it. Okay. It has to do with the face shield. I was recently talking to a colleague doctor. I have seen people wear the face shield without face mask.
All right.
And I have been a little worried because, well, the face shield is good. It protects your face entirely. But I don't think we should only look at the face shield and take away the face mask. Because, you know, recently, WHO said that the virus is not airborne.
Yeah.
For more than 8 hours, it can be in the air. So if you are only wearing a face shield, it may not protect you entirely.
You'll be breathing in.
Yeah, exactly. So I think that Israel, we should start educating people in such a way that the face mask is the #1 priority. Put it on and put on your face shield. I think it will help than only putting the face shield and leaving the face mask.
I'll let Dr. Patrick Aboagye make that point. Doc.
Thank you, Israel. I think you're right. The workplace is an important challenge, and that means that people feel a bit more relaxed because they have people around them, and then they feel it's the one coming in who is potentially infectious and not their colleagues. And so we've had a few, I would say, outbreaks. I won't call it major outbreaks, but for a workplace, if you live in a building that houses 200 people in separate offices, once you remove the walls, it becomes a mass gathering. And so that's what I was talking about, institutional arrangements that make sure that these things are not done. And so it's an area of concern. And then they are bringing it home, from home to the facilities, to the workplace, and taking it back home because they get infected. So it creates a major problem. And that's why we feel that, if you have noticed, in the last few weeks, we have been focusing on workplaces. We are going there to do risk assessment and making some arrangements to make sure that infection is significantly reduced. Remember the Tema incident where we had about, even though you have 533, there were about 695 positives eventually in one area. And so it's a core area that we need to look at. And so currently we have enhanced their protocols. We have also given them rapid orientation, regular orientation for people to see everybody. And it's the same, a hospital is also a workplace. Nurses and doctors are very cautious when they are going to the patient, but when they come to their colleagues, they remove their masks. So these are all areas that we're trying to reinforce to ensure that these things are done. Now, the schools. I think in the area, when we talk about the schools, before we open, we appreciated that, especially where they're going to boarding house, there will be challenges. That one, there was an effort to ensure that we have, one, the masks were given to students, sanitizers, hand washing facilities were provided, teachers were oriented. And we're hoping that now that they are in school, we have a few outbreaks, which was expected because we anticipated that some students will come from their house with infection.
All right.
And so now what we have done is we had already marched all those secondary schools to hospitals. We have been enhanced. That's why we have been able to pick them disease early. And hopefully in a week or two, when we have settled, we've been able to isolate and quarantine and isolate the people. There'll be some peace for them to be able to take the exams. Because when we are talking about living with the virus, there are certain things that we need to continue doing. And so, like you said, prevention is the most important aspect of it. And so currently, we have had 1, 2, 3, a few, probably the maximum is about 6 or 8 cases. We are hoping that we are monitoring to see how it's done. But we are consoled by the fact that they were picked very early and they are not being allowed to stay and spread. And so that's why we'll continue monitoring and see how we hope it.
All right. Thank you very much, Doc. Now, so I told you my co-anchor is Louisa Line, my wife. She's here. So somebody has sent through a question or a comment. So Louisa, share that with us, please.
Okay, it's a question. And it's a concern as well. This is from Emmanuel Amoafo-Mensah, and he says, Okay, so I said it seems I've contracted this COVID because I started feeling feverish and sudden loss of smell afterwards. Initially, I went to the pharmacy to get some malaria drugs. I was a little okay, but still couldn't feel smell. I went to the hospital last week for a test, and I'm still waiting for the results to come. I was told I will only be given drugs after the results are in. But Israel, I'm just at home and it's not getting any better. Can you ask your doctors for me what I can do while I stay at home? Maybe if there's a drug I can get. My network is so bad, I can't follow the program properly.
All right. So, Dr. Aboagye, you have did you get the question?
Yeah,
So,
I got a question.
So the gentleman says he felt some symptoms, got some malaria drugs. He felt a little okay, but he still can't smell anything. And he's taking the test. The results are not in. And he's been told he can't be given.
Yeah, I got a question.
Okay.
So he's worried.
Yeah, okay.
Right.
Maybe add this one. Generally, loss of smell or anosmia is one of the major signs of the condition. And yes, we apologize for the backlog that we've had and the challenges. But as of this weekend, we have enough supplies to be able to quickly catch up and do the test. But my advice to the person is that if you are not feeling well, we have places where we have, if you go back to the hospital, where you have a holding area for suspected cases who are managed waiting for their results. So it is not good to stay home just waiting for a result. If you feel unwell, you'll be managed in the holding area as a suspected case until your results come. And usually, if you have Dr. Komi, you are treated as if you have COVID until your results come, because some of the clinical signs are quite clear, especially when you have loss of smell. That will be done. And then if you go, they may be able to also either expedite it or probably take another sample and have it fast-tracked for you to be able to manage. So that's the advice I'll give. I don't know what Dr. Owoo or Komi also has to add.
All right. Let me bring in Dr. Owoo. Dr. Owoo, what do you have to say about that?
Yeah,
and about anosmia.
Yeah, so anosmia is quite one that we are finding to be very, very high in its sensitivity. It does not mean that there are no other conditions that will cause loss of smell or loss of taste. But anosmia is one that we are finding to be quite significantly sensitive. So what I would say is for this particular participant, you can reach out with my number or Dr. Oliver Komi's number so that we can actually assist in channeling to where you can get care, okay, and then assist him. But
so just to be clear, you're saying I can pass on your number to him.
My number to him. Then we can, depending on where the person stays, we can assist the person in getting appropriate care. If we think that he can still do home care, we'll assess that. Then we'll have a team reach out to him or her. If we think that it's inappropriate because of other symptoms that are significant, then we'll advise on to which holding area in which facility. And then as the Director General said, then we can also assist in getting the results sorted out quite quickly. So you can pass my number or Dr. Oliver number on. Right. But just to make just a few remarks, because I'll be stepping out quite soon.
We're actually ending. We're supposed to be ending by now, actually.
Okay, so let me just this just 30 seconds. When Israel, you spoke to me about this, one of the major things that we agreed to do, and we probably will be doing subsequently, is bringing in some of our survivors from critical illness. Yes. Those who came close to death, look at them. Yes, and then let them speak to others. I have resisted the request for almost 3 months because of what we mentioned earlier on, that it's not only surviving critical illness, the trauma, the psychological trauma that comes with it is very significant. And we had clinical psychologists and in some cases psychiatrists work with them to allow them time and space to recover to be able to come to terms with this and to even decide whether they are happy to share their experience.
Stories.
A number of them are ready to share their experience now. We've assessed some of them and we think that they're ready to assist others to let people know reality of critical illness in this. So subsequent ones, you would have some of those join us to tell their story.
All right. Thank you very much.
Israel, please, before Dr. Owoo goes away, I want to ask something small based on the young man's input, the message he sent. Now, I want to find out from our senior colleague said that, do we have protocols that looks at a patient who should be detained and a patient who be sent home? I mean, a patient who come to report that, or I have these symptoms and that I need a test. Do we have any protocol that clearly defines a patient who should go home to self-isolate and a patient who should be detained? Because for this particular young man to have an anosmia, even though there are other causes of anosmia, I mean, we know that once we have COVID around, COVID should be our first differential. So in this case, it's like that he may be positive.
Yeah, that APPIAH could be, just not to cut you, because the answer is quite straightforward. Yes, we do. We have full guidelines. We are actually on the 5th draft of our guideline, which is being published as we speak right now at the moment. So yes, we have guidelines for everything, basically almost everything you mentioned with respect to Hong Kong. We have guidelines for all of them, health workers, hospital, isolation, every single one of those. But you should know that also that these are also emotive issues. So sometimes people step out of the guideline. When they step out of the guideline, we will not say that because you step out of the guideline cannot assist you. So, and of course, there are also challenges with logistics that sometimes will create some difficulties. But yes, there are guidelines for who should have home care, who should have institutionalized care, who goes to, who is moderate, who is severe, who goes to ICU. But of course, these are also dependent on logistic challenges sometimes. Yes, and we even have where, who should you reach out to? And that's why I didn't go to say, have you called 112 or have you called COVID Connect? All those are available. But when you have individuals reach out, it means that they may also have challenges that they would want to speak to somebody about. And that's why I said, when he reaches out to us, we can, apart from assisting him personally, we can also assist to link him back to the pathway, the care pathway.
Israel, I asked because the attending physician who saw him maybe shouldn't have let such a patient go back home. That's why I asked, because with his symptoms and what he came with, and even if the test wasn't in, maybe such a patient should have been isolated or asked to stay, or I mean, get a corner for that patient to stay so that he doesn't go back to the community to, if that patient is not so careful, he may have already infected some few people already before we see to him. That's why I asked. Thank you.
Yeah, I agree with you. So we'll assess that when he tells his story. It's not so easy finding that out just from his initial submission. So those are some of the things we assess. And I agree with you that those are important.
Yeah. All right, so thank you very much, you all, for making time to join this webinar. I'm sure it's been helpful. As I indicated, this is something I want us to be doing every week because COVID is here. It's going to be with us for what? I don't know when is COVID going to go away. I don't know if anybody knows when COVID is going to go away. So for as long as COVID is going to be with us, we have to learn to live with it. And so these conversations are very important. And I'd like to thank all my guests who made the time to join. There's some who are on who didn't say anything. I'm sure you've been listening. So I have, first of all, and I think we should all say something, we should all commend Nana Tima for coming out to speak, because it's not easy for people to come out and share their stories about COVID-19 because of the stigma. So thank you very much, Nana Tima, for coming out to share your story with all of us. Also, Dr. Patrick Aboagye, the Director General of the Ghana Health Service, for making time to join this conversation. Dr. Chris Owoo, who is the head of ICU, the National COVID-19 Case Management Coordinator, for severe and critical cases. And then Dr. Anima Addae, who's a member of the National COVID-19 Case Management Team for severe and critical cases. Dr. APPIAH KUBI, who reached out to us from all the way from Hong Kong. Thank you very much. And Dr. Amoafo-Mensah, who also joined us from London. I thank you all, and I appreciate the time that you made for all of us. You have a wonderful day, and do stay safe so that none of you will end up getting COVID-19.
Yeah, thank you, Israel.
All right.
Thank you, Israel.
Thank you. And Dr. Oliver Comey as well, thank you very much for your contribution, and anybody else who could join us. So let's make time same time next week. Have a good day.
Thank you.
Bye-bye. Bye-bye.
Bye.